gamba sotto terapia compressiva.
So, hello everybody. First, I would like to thank the organizer for inviting me for this interesting meeting about compression in DVT. And as you see, my talk is about anatomy of the veins of the legs under compression, which is a very interesting topic because we do not know all about compression, as you will see. So, what is this one? So, as Professor Part showed you, the compression therapy needs to narrow the veins of the patients. This is important to achieve an hemodynamical effect on the veins, and also it fights against venous hypertension and stasis, as you know. And precisely this anatomical effect on the caliber of the veins is crucial to prevent DVT and treat DVT, as you saw previously. So some reminder about anatomy. Could you lower the lights, the big lights, please, for the images? So venous anatomy is not well known, and as you, thank you. Two things are very important regarding compression effect in this study are the compartments. That is, what is, sorry. It's not possible to lower the light. So, okay. So, the three compartments, that you know that, and the D vein of the leg, some word about that. First, the three compartments, as you know, it's a consensus opinion, which was stated in UIP-ROM in 2001 and published in GVS. And you know that these three compartments, the superficial are two, and one of the two is between the two facial layers in the saphenous compartment here. But the most important thing is the division into the deep compartment and superficial compartment, that is aponeurosis here. This is mostly important because the intramuscular pressure is a special compartment, and it is separate, completely separate from the other compartment, the superficial. And why is it so important? Because this division, due to this division, you have an intramuscular pressure which is very low at rest, but which could reach more than 250 millimeters of mercury during muscular contraction. So this is very important regarding the effects on the deep veins, which are inside this compartment. So, and second, I would like to highlight two things about the deep veins on the leg, which are not very well known. You should consider the axis of the deep veins, which are these that you know, anterior tibial, posterior tibial, and fibular veins, but they are only way of passage of the blood. But the more important veins are the muscular veins, because this is the calf pump, this is the motor of the venous return. And as you know probably, and I will show you briefly, in these muscular veins are in two parts, which are so different. The veins of the soleus, which are at the leg level, and the gastrocnemius, which pump is located at the popliteal level up to the knee. So here you can see the difference. Here you can see these veins are painted in blue, are posterior tibial. These in pinks are the two fibular veins, which are the axis veins of the return, but this is, on the right, is the active part, which is much more important, as you can see here clearly in this anatomical dissection with latex ingestion of my teacher Giro. And you can see the gastrocnemial vein here and the fibular veins in green here. So it is a sponge of blood, and this is the active part of the venous return, activation of the axis. So here you can see again the posterior tibial veins here. You can see the perforator, which are colored in red, and their relationship with the saphenous vein, but not exactly saphenous, but the tributaries, as you know. And here you can see the soleus muscle open, and which is important. What you see in this slide is the connection of the perforator, here in red, which are always located in the same locations here, and the relationship with the posterior tibial. But you should see that. That is no importance of the axis veins. They play a role, but the most important thing is that these perforators are always located at certain locations which are the convergence of the big soleus vein, which is the motor of the system. So you see, this is important about anatomy. The muscular veins are much important, more than the axis vein. Second, just a word about the soleus vein muscle, which are not well known. You see, the systematization of the soleus is very simple. The lateral part is the more important. You see in green the soleus vein here. These veins are draining in the fibular veins. This is the reason why the fibular veins are bigger than the posterior tibial here and are big in from this middle part of the leg. And second, in blue here, on the medial aspect of the soleus, which is divided in two, as you can see here, you have the veins, medial veins, which are draining in the posterior tibial veins here. So, once again, it is a fantastic sponge of blood. This is the soleus muscle, completely open. You can see the lateral veins in green here, bigger than the blue ones, which are the medial ones. And once again, these are draining in different veins, different axis veins. The lateral in the fibular and the medial in the posterior tibial vein. So this is explaining how the motor of the pump is working. So now let's go to the imaging techniques and the anatomical effect of the veins. So for that, of course, you have Duplex US. I will skip with venosity because it is lying position only, and the most interesting is what Professor Hugo Part showed you previously very quickly, which is MRI in standing position. So first, the Duplex. It's well known when you use a cuff, a special cuff with a transparent window, you can have a look at the veins to exert a pressure and look at the venous caliber, so you can easily see what happens. And in a nice paper, Hugo showed very nicely that you see here the siphonus in the compartment. You see that with the cuff, to obtain a flattening effect of the siphonus, you should apply 40, but if you want to completely squeeze the vein and disappearing the vein, you need 60, that is in sitting position in the superficial vein. We'll see more information. To achieve a venous occlusion, you see, it's different, of course, according to the position. In supine, you need something like 20 and 25 to achieve a complete occlusion of the vein, complete flattening. In sitting, it's a little bit more, that is 50. And in standing, it's more, it's something like 70, as Hugo showed you. So, and if you want to achieve a complete narrowing of the deep veins, it's beginning at 60, but if you want completely flattening and close completely the vein, it's something like 90. So it's a very, very high pressure. So this is an explanation why we had a dogma in compression therapy. The dogma is that the compression of the deep veins require a higher compression, higher pressure than the superficial vein. This is something logical because the veins, superficial veins are just below the skin, but the deep veins are inside the deep compartment, inside the aponeurosis, so they are difficult to reach. So you will see that the results that I will show you with the MRI, just to call this dogma into, yes. So this dogma is called into question, and this was a very interesting presentation that Giovanni Mosti and Hugo Parch made in the American Benelux Forum in 2010, showing these slices that Hugo showed previously. And this is very surprising because you see here with no compression, the shape of the leg is different because the stocking around the leg is modifying the shape of the leg, it's rounder. And second, of course, which is very interesting, is that you have here big veins, which are the veins of the soleus I showed you previously in the anatomy. So we have very big veins in standing position with no compression. And this is very surprising that if you apply a light compression, that is something like 22 millimeters of mercury, a stocking, they disappear. So it is sufficient to make a compression, but it is so in the soleus it's very, very visible. On the deep vein axis also, because you see here the fibular veins and the posterior tibial here, they not disappear, but they are flattened a little bit. But the most important feature is that the superficial vein, which is here a big varix on the medial aspect of the leg, is not affected at all by this pressure. So with this, making a partnership with Hugo and Giovanni Mosti, we made a study in my university because I am a professor of anatomy and specialist of 3D modeling and imaging. So we use very frequently in my department vectorial modeling. And we use all this very nice data from Giovanni and Hugo. And we made a 3D vectorial modeling of all the leg in order to better understand what happens. So there is a material is 12 adults. Some of them have varicose veins, 4 or 5. And we in different positions, that is supine, prone, standing, and of course in wearing different medical compression stocking with different interface pressure. And of course always the interface pressure, which was exerted by the different bandages or stockings, was assessed with a sensor that is measurement of the interface pressure, which is a picopress. So all these patients were investigated by MRI, and you can see there were different, this is an MRI. It was different protocols because it's not very easy to make a unique protocol, but you see different number of slices, different thickness and different lengths. But anyway, it's not the full leg which is assessed, but a part of the leg which is the most important part, which is the calf part, that is the higher part of the leg. From the apex, you see the B1 point, from the apex of the calf to the knee, so this is the most important one. So what did we do? We made a vectorial modeling of all these veins, also the bones and the muscles, and this is very interesting with a special software, and drawing the boundaries make it possible to quantify the venous volume and to obtain realistic 3D model that I will show you. So this is the software. You can see here the tools by the software. You have a pen, and with the pen you draw the boundaries. That takes a long time. I did that with my students in the University of Paris Descartes. And you see the different colors here. And when you finish all the slices, that takes some time, you will have a nice 3D model that we call a mesh model. You can see here the skin in white, the bones and the veins. You can remove the bone, you can remove the skin, and you can have a nice realistic, what we call a ray tracing on the vein, making a very realistic model of the veins. So this is of course interactive, and you can see here with a compression stocking what happens. You see the varix on the left, which is a big one, not modified. You see the without compression. And you see here the deep veins, anterior tibial here, posterior tibial and fibular, which are a reduced caliber. Because the reduced caliber, if we compare with no compression here, and you can see the big fibular veins and the big veins of the soleus, I showed you previously in the anatomy, which are here, they completely disappear as you saw in the slice. But this is better to do that in 3-dimensional. And what is the big advantage? The big advantage is to quantify. So we can quantify each of these veins, that is the volume of the vein, and this makes possible to compare the standing position with no compression with the standing with this slice stocking in red. And you can see here on the bar and the figure that it is mostly in the deep system, that is in the fibular and the posterior tibial veins, that you have a reduction of volume, but in the varicose veins you have a very, very small difference. You see, you remember the figures. And more obviously, you can explain that in the reduction of vein volume in person due to compression. And the summary of this is in the deep system, you have a big reduction. It is only on this patient, a particular patient, in big C2 patient. You have a reduction of 71% in the deep, overall deep system, while you have only a reduction of only 8% in the superficial. So, of course, similar results are also in supine position. Not so beautiful, but they are, because it's the same effect of compression or contraction of the muscles. So you can see here, at rest, with no compression in the lying position, and when you achieve a muscular contraction, you have the same effect, that is, the deep veins, posterior tibial and fibular, have a big reduction of caliber due to the muscular contraction, of course, and during that time, the superficial system has no modification at all. So what is the pressure which is necessary to achieve a complete flattening of the superficial veins? That is shown in the same patient, always the same patient with different compression. You remember the 22 millimeters of mercury pressure, which is a blue one. So no reduction at all in the varicose veins. But if you increase the pressure at 51, it's not, you have no reduction. But if you make more than 70, as Hugo showed you previously, you achieve a reduction, which is a big flattening of the superficial. So it's a very high pressure which is required to reduce the caliber of the superficial veins. So now, of course, this dogma we saw previously is true at rest in supine position. If you have at rest, no contraction, and in lying position, you will have a reduction with a small compression, which is 20, sorry for the title, 20 millimeters will reduce the superficial vein, but not affect the deep veins. It is only true at rest in lying position. Now, some more results about this. This is a global result. This was only one patient. Now, let's see the group of patients. We have 8 C0 patients and 5 C2 patients. First, what is the reduction of the volume that we achieve with compression in standing position? Or all these patients, you see, it's a little lower than the patient I show you, but you see that, of course, the reduction in the deep system is much more important than superficial. So it is confirming the first patient. Second, what is the modification of anatomy of the vein according to the position? If you go from supine to standing without compression, that's no compression, it is an average on 5 limbs, you can see, of course, that if you go in standing position, you will increase the diameter and the volume of the superficial vein, which is well known, of course, in standing, and you will not modify a lot the overall deep vein system. It's a little bit increasing in the gastrocnemial and lowering in the fibula. Now, what is the effect of muscular contraction in supine, not in standing, just in supine? You see in the group of, this is a C0 patient, you see here that you have an effect of contraction which is observed without compression, that is a reduction of the deep system. This is due to muscular contraction. But on the right side, you can see with 30 millimeters of mercury compression, you have a much more important reduction of caliber of the deep veins. This is the effect of compression. It is increasing the effect of the muscular contraction. It is important. So, and lastly, when you make, it's the same because it is in supine position, but this is the average with a lot of patients. That is a group of 8 patients. You can see here, you increase the difference between resting and contraction. It is in supine position. You increase the effect of reduction of the deep veins when you add a compression stocking. That is the same result that I show you with the one patient. So, right. So, just 1 minute of discussion. Of course, this technique has some limitations. That is a long acquisition time, the limited segment of the calf, which is studied. And the summary of this is that you can achieve a flattening of the superficial system with a low pressure in supine, which is about 25 millimeters of mercury, but if you want to achieve this in standing position, you need to apply a very, very high pressure, which not, we have to keep that in mind. 70, it's a lot. And so, and you see here, but the compression in the deep is different. The compression in the deep is related to the muscular contraction because we are inside the deep compartment, which is important. So this is the reason why, with a light pressure around the leg, you could have an effect of the muscular contraction and increase the effect of the muscular contraction, and so have a reduction of caliber of the deep veins. So this study is interesting because we are studying the compression and understanding more and more things, but not all just now. But you see, the result of this is probably the stockings are, the main effect of the stocking are to enhance the effect of the muscular contraction. And Hugo explained you that he prefers short stretch bandage. And you remember the curve with when you walk with the muscular contraction, the massage effect. So this is important. When you walk with compression, you will enhance this massage effect, which is so important, probably the more important effect of compression therapy. So, and you see, and this is regarding this meeting about DVT, it is a good explanation that with light stockings, you could have a preventive effect of DVT and, of course, a therapeutic effect on DVT. So, what is explanation of that? Probably the muscular compartment, which has its own pressure, is important, and probably the medical compression stocking could be considered as the kind of extra aponeurosis enhancing the effect I mentioned previously. So, and all this is confirmed by different studies showing the short stretch bandages, you see, because you have with stiffer material and we're going to go to the compression stocking, you have a higher effect on the pump function, which is the same as I showed you previously. So now, to go and to do more about this kind of study, we could have more interesting things. It is necessary to use what we call the finite element method. And Fedor Lurie showed us recently some interesting point about that, because this was the effect of the vane. To explain the effect of the vane, you should have a study of the muscles of the compartments and the whole effect of the anatomy of the leg. So this is the finite element method, which is make a simulation. You have a mathematical modeling of the anatomy, which could explain what happened on the vein from the modification of the shape and the volume of the muscle and the compartments. So this is a work in progress, and you see the effect of compression is very interesting, but not well known, and I thank you very much for your attention.
Thank you very much for this brilliant presentation. There is any question from the audience?